In January 2021, staff from the Robert Wood Johnson Foundation invited me to lead an expert panel focused on transforming public health data systems to promote health equity among LGBTQ+ communities. That sounded pretty good. Together, we recruited a dozen people with a range of relevant professional and lived experiences. We brought this amazing group together for a series of discussions on Zoom, organized around 4 questions. What do we want for LGBTQ+ communities? What do we need in order to achieve our vision? How do we get there? And what needs to change about the way data are currently collected? We came up with a set of recommendations that we share with the Foundation, as well as the National Commission to Transform Public Health Data Systems. The National Commission then released a report in October, but that wasn't the end of the process for us. We still had work to do.
Because much of our panel discussion focused on LGBTQ+ youth with multiple marginalized identities, we decided to recruit youth and young adults ages 18 to 25 to serve as youth advisors and to inform the second phase of the work. We worked hard to ensure that youth leaders were diverse. In addition to holding a variety of gender identities, sexual orientations, racial and ethnic identities, youth advisors include a child of immigrants, an asylum seeker, and people with experiences of housing and food insecurities, adverse mental health, disability, and neurodiversity. We asked the youth leaders, did our report get it right, and to interrogate what right meant. We asked, what did we miss, and what should we modify to communicate best the changes needed to promote equity for you and your peers. In total, 11 youth advisors participated in 3 online meetings and each produced a final project: a zine, video, script, graphics, art, draft legislation, and an informational pamphlet. Youth advisors were compensated for their labor. By adopting this youth-focused approach, we were challenging traditional understandings of expert by listening to and compensating youth experts who served valuable roles in this important endeavor. We are thankful for the youth leaders' shaping of our group's recommendations and for informing the way that we approach this work more generally.
Social justice is an essential precursor to health equity. This requires transparency in how and why data are collected, accountability for harm done, and a commitment to interrogating and redistributing power. It also requires addressing root causes of health inequity: white supremacy, colonialism, racism, anti-Blackness, sexism, cissexism, heterosexism, ableism, that are all embedded in these systems. We need institutions to restore trust by acknowledging the harm they have caused and demonstrating an ongoing commitment to doing better and remaining accountable to marginalized communities. In 2019, the American Psychological Association apologized for previously treating homosexuality as a mental illness. In 2021, the association made a public statement against gender identity change efforts, including conversion therapy, acknowledging the fields of psychiatry and psychology have a long history of pathologizing individuals and those who question their gender identity. We need more of these kinds of efforts to address past wrongdoing and prevent new harm.
Government data surveillance systems focus too much on individual health behaviors like substance abuse and sexual activity. This data is critical, but an exclusive focus on individuals risks blaming poor health outcomes on the characteristics or choices that individuals make, rather than on the failure of the institutions and systems themselves. Data should expose discrimination, not pathologize individuals. That means collecting data not only from the systems like education, social service, criminal justice, healthcare, but data about these systems as well. That can hold them accountable for providing high-quality care regardless of the identities, income, ability, or geographic location of those they serve. During my time at GLSEN, we added new items to our national survey of LGBTQ youth that really assessed the education system itself, like dress codes and access to gendered spaces. We also surveyed educators, principals, and assessed policies. This research identified gaps, problems, and best practices of schools, allowing for a focus on changing the system, not the student.
In order to address long-standing social, racial, and economic inequities, public health systems must acquire a lens of radical imagination. This requires leaders to clearly see the present, its problems, and its precursors within public health. Seeing clearly gives a rise to the possibility of imagining what else could be. We could imagine expanding data to include people's experiences beyond traditional sexual orientation and gender identity designations. Uphold the humanity of stigmatized, marginalized communities, and not focus on people as problems. Emphasizing a care ethics lens focused on thriving and centering healing from interpersonal and institutional harms. Promoting social justice, not social control. We find inspiration in a number of community-based initiatives that have reflected this kind of care ethic and through radical reimagination. One example is pod mapping. Pod mapping is people creating a physical representation of their sphere of influence and connection to visualize the usefulness of other people and what you yourself have to offer to others.
Focusing on wellness and thriving. Too often, for marginalized communities, the focus is on health disparities and negative health outcomes. Health equity is not merely the absence of negative health outcomes, but should be understood from an asset-based perspective. Data measures should focus on thriving, healing, resilience, and connections to supportive adults and peers. As an example, focusing on research and data on youth leadership, resourcefulness, healing, and forward momentum is central to the series Policy Research EBP Plus model.
Marginalized communities should define for themselves what health equity means. This means centering the voices of most marginalized members of the LGBTQ community, including Black, Indigenous, and people of color, people with disabilities, and people with low income. It doesn't mean holding these communities responsible for fixing and overcoming the oppression they experience from harmful systems. The US immigration system is one of the most harmful against human rights. LGBTQ community and immigrants and refugees are frequently denied Medicaid, Social Security income, financial aid, housing support, and employment. They live in constant fear of deportation. They are often discriminated against because they are perceived as foreigners. The constant question, "Where are you from?" is part of this discrimination. This is a deeply personal question that can be harmful. It is reminding people of their trauma, ineligibility for resources, and legal disenfranchisement. This is not a welcome question, it is an othering question. If an American citizen who might hold a similar identity with an immigrant asks this question to them, they're being insensitive towards them. Together with transphobia, homophobia, and racism, this form of discrimination contributes to violence and feelings of worthlessness and have negative consequences for the health of LGBTQ immigrant communities.
I'm an academic researcher, and I know important data collection takes place outside of academic institutions. Investment in the research capacity of nonprofit organizations is essential to addressing data gaps and promoting health equity. These organizations often have a better understanding of the needs and perspectives of LGBTQ+ communities. Foundations and government agencies should invest in these organizations and their staff through technical assistance, training, fellowships, and college scholarships. The National Center for Transgender Equality is a good example of a nonprofit organization doing impactful research. NCTE launched the U.S. Transgender Survey in 2013 to collect information about the lived experience of the wide range of people who identify as transgender, because the federal government simply wasn't doing it. That study has been a game changer for policy work, academic research, and for cultural change, because it quantified the discrimination and violence transgender people face every day.
We need to listen to and compensate those impacted for meaningful roles in research. Centering those voices is essential to the transformation of data systems to promote health equity. This requires hiring and promoting those of LGBTQ+ and color. Lived experience must be valued in the same way that educational degrees and professional credentials are. This may require modifying or eliminating educational requirements and not linking salaries to those degrees. Hiring people with lived experience should include leadership positions, not just frontline work. An example is the William T. Grant Scholars Program, investing in early career researchers. The new Gaingill Scholarship is open to any LGBTQ+ individual, including immigrants and undocumented people. This initiative is one such example. The Youth Advisory Board includes those in middle school to recent college graduates, all being compensated equally for their time and effort, abiding by the principle that lived experience should be treated equal to age, background, and education level attained.
Before agencies collect data about sexual orientation, gender identity, and expression, also known as SOGI, staff need to understand the meaning of these concepts. Training should underscore that all youth and adults, not just those who are LGBTQ, have a sexual orientation, gender identity, and gender expression. Staff should be encouraged to have mindful, open, non-judgmental conversations with clients about their SOGI to incorporate the complexity of identities they possess, including those across race and ethnicity. Staff should also understand the fluid nature of SOGI and be willing and able to revisit these conversations with their clients. In addition to training, those developing administrative data systems, including private software vendors, need incentives to adopt SOGI data standards and integrate SOGI data with care and intention. SOGI integration is beginning across justice, youth care, child welfare, and public health systems. In terms of intentional design of administrative data systems, you can ask SOGI questions, but if the data can't be captured in administrative data systems, then it does very little to inform programmatic policy and funding priorities. If your reporting requirements don't require you to report on SOGI data, or if they only offer limited categories for sexual orientation and gender identity, report the full range anyway. This is how an agency I worked with eventually got their funder to designate money to updating the data system. We always added an addendum with the range of young people's genders. And as a side note, please don't put SOGI info in the mental health or sexual risk behavior section of your forms. An example of a comprehensive training program I can share with you comes from an organization in Nashville, Tennessee, that developed a video training series for foster parents and foster care agency staff at all levels of the organization, engaging them not only around how to ask about or talk about SOGI, but also how being in an affirming environment positively impacts young people in care. This is a really, really important point because you can't just ask SOGI questions in a vacuum. It needs to be done within an organizational environment that signals safety and acceptance to LGBTQ young people so that they can feel comfortable engaging in these really important conversations.
Transferring data systems requires broadening what we perceive as good and useful data. Collecting our lived experiences is important. It should be seen just as valid as quantitative data. Better training in recognizing, collecting, and utilizing our lived experiences is needed to transform data systems. I did this in my community and asked young people who exist in the trans and queer communities, what do they want people to know about them? When analyzing this data, there was so much information that I learned. So what data exists inside of you? How does data transform what people once knew?
Youth-serving agencies all use data in some way: child welfare, youth justice, schools, mental health. Some need intake data. Others collect assessments like needs assessments, behavioral health assessments, mental health assessments. But if we want to understand LGBT youth across all of these different agencies, we need systems to collect what we call SOGI data: sexual orientation, gender identity, and gender expression information. And then we need to link all of these agencies' case management systems together so that we can coordinate and understand what's happening in many different contexts. For the first part, Series Policy Research has developed what's called the Whole Youth Project. We train probation departments to include SOGI data in their case management systems. A similar model could be used with other agencies. The second part is more complicated. We need cross-system memorandums of understanding and infrastructure to transfer and combine data sets. We can get through these complications and challenges. The one thing we need to keep in mind, though, is we need to protect the young people who are sharing their information with us, as well as the LGBT community at large.